Hello, and welcome to another episode of Talking All Things Cardiopulm. I'm your host, Dr. Rachel Barisi. All right, so today is part 4 of tackling the MOSC. I'm almost certain this will be our last podcast in relation to completing the MOSC application. And what we're going to be discussing today is the case. So, in my opinion, this is the most time-consuming part of the MOSC. And just a couple of tips leading into this. And I probably have already alluded to some of these things, but I think it's important to kind of state them up front. If you're in the process or know that you have to complete the MOSC, whether you're at the beginning of the 3-year window or at the end of the 3-year window, if you know that you're in this cycle and you're like, I'm going to start inputting, pick a case that will be easy to write about. Pick a case that moves you. Pick a case that you are prepared for. Pick a case that you're going to utilize a number of different skill sets. Pick a case that has maybe some important external, internal factors that you have good reflection points on, right? Like at the end of the day, you get to pick what you are showcasing, right? And the whole point of this is that you're showcasing your skill set. So, pick accordingly. Pick a diagnosis that excites you. Pick a case that maybe, like for instance, if you're in an acute care setting, I always recommend people who are in the acute care setting to pick someone that you're going to see potentially more than once, or potentially see for their entirety of their plan of care. And if you maybe have the ability to keep a patient, that would be, if you're writing a case on someone, that would be one to do. And then my recommendation is to fill out this case either during the time that you're seeing them or right after, because it's going to be fresh. You're going to have access to notes. You're going to have access to those conversations that you've been having. You're going to be able to really reflect on how you feel or why you chose something in that moment. And I think the case will be much more fluid. And the reason why I'm saying I think is because I've never done it this way. And so for future cases, this is my plan, or future MOSCs. So I have completed 1 of 3. I have another 2 cases to write. I'm actually going to start my next one probably after this podcast. And they are retrospective. So I have some case information from a few specific cases that I thought were important and kind of held on to. I keep everything with, major health condition interventions, like a list of things in preparation for this type of, case, or if I'm going to potentially utilize pieces of it for maybe like an exam question or what have you. Everything is redacted, but sometimes a case kind of pulls you. Sometimes you end up seeing a patient for a few days at a time, and especially being PRN, I kind of grasp onto those when they happen, but they are all retrospective. The ones that I have picked, I remember those people. I remember those conversations because they kind of, they linger. You had some sort of connection. You had some sort of impact that really kind of drives you. And so I do recommend when you pick your case that you pick one that kind of moves you in some way, shape, or form, whether it's a diagnosis that you like, whether it's the story of the person or their improvement along the time that you've seen them, whatever it might be. And then what I do recommend is that if you know that you're going into a case or you're, seeing someone who you think, oh, this would be a really great case to write about, make sure you kind of plan accordingly. Make sure that you are utilizing specific tests and measures. Make sure that you are utilizing at least 1 outcome measure, maybe even 2 or 3, right? Maybe you add some things in as the person starts to progress, whatever it might be, but plan for it, right? This is your case. This is your time to showcase your abilities, your thought process, your clinical decision-making, whatever it might be. Okay, so we're going to jump in, and I have the kind of case outline pulled out. And I actually decided to do this because I kept getting locked out of my GCS case. So let me actually throw one more piece in here. So if you are an ABPTS specialist and maybe you were never put on the MOSC track and you're like, oh crap, I don't know what to do. I'm too late. I'm just going to have to resit again. I was in that same boat. I told the story a little bit about the GCS. It was not a thing when I finished the GCS, and so I was never like put on that track. And I honestly never took the initiative to like put myself on that track to like notify ABPTS, hey, I have this specialty. No one has ever told me to do this. It wasn't until I was getting close to that 10-year mark that I was like, you know, what's the plan here? Like, is there any information for me? So when I reached out, they opened the MOSC cycles. So I had to kind of retroactively put information in. So just reach out to them. They are very quick to answer their email. So like shout out to the ABPTS for being really quick on responding. And then I do recommend if you're doing something retroactively, like I have a cycle that's, one section before, ask them to open it for 30 days. If you don't ask for a specific time, they give you like a week, maybe less than a week. And so if you start to go in and, you get busy with life and you go back in, you're going to be locked out, then you're going to have to ask for permission again, so on and so forth. So my recommendation to you is if you are behind, don't panic. Reach out to the ABPTS, explained that maybe you weren't set up on the track. If you have been locked out of a section, ask them to reopen it. You are not the only one. So I'm just going to put that plug out for you because, there's not information for your specific scenario. And that's kind of how I felt. Okay. So one more piece of like reflection after having like gone through this now multiple times in the past year. When you're writing your case, sit down and write your case. Don't try to do a little bit here, a little bit there, a little bit here, because when you go back in, you're not going to remember which sections you really hit. There is a lot of overlap. So if you're working in it in the moment, you're going to be able to catch that overlap kind of throughout. All right, so the case itself is, I believe, 9 sections in length. Yes, so there's 8 sections, and then the 9th section is considered a summary reflection, and that's where you add your references. So I mentioned this in a previous podcast, but as you're kind of writing up your case and keeping track of the things that you're doing, if you utilize a specific outcome measure, gait speed, 30-second sit to stand, 6-minute walk test, whatever it might be, start looking up your information for articles that support the use of that outcome measure with that diagnosis, so on and so forth, just like you would be creating a lecture of some sort. Of the 9 sections, there are some like asterisk things that you have to fill out. Essentially, you have to fill out 9 sections, but you only have to fill out 2 reflections out of that 9. And honestly, the first 2 don't have a reflection section. Okay. So my first piece of advice before you even start going through the sections, like obviously read through it, kind of see where things are laid out. I actually copy pasted the sections onto a Word doc so I could work in my Word doc off of the portal, just because you kind of get logged out if it's stagnant for too long. And I can save and I'm not worried about it losing, whatever. Read through it. Each section has a section of reflection questions built in to sort of trigger or encourage specific verbiage or thought process and kind of pull some stuff out of you. Most of the sections have some good guiding questions. The first section, I think, kind of missed the mark, but we'll work through that. But what I do want to say is before you start filling in the sections, I highly recommend that you fill out the ICF chart first. And the reason why I recommend that is because that's going to lay an outline, a foundation for you. And so if you have that created and you sort of just kind of have it up on a second screen, or even if you print it out, it's going to make your flow in your other sections much more fluid. And then there's going to be less going back and forth. Plus, you kind of get your ICF verbiage out of the way and you can keep plugging it in throughout the case. That's really what I recommend. That's what I'm going to do in my next case report. All right, so the first section is the health condition section. As we talked about last time, the health condition is really just that diagnosis, cause, injury, medical piece that opens the plan of care for your treatment. Okay. In the health condition sections, they want age, gender, disease, disorders and injuries, medical diagnosis, so like your past medical history. The idea of it is that, it's the initial data gathering kind of thing. This is like the opening sentence. Patient is a 38-year-old female with past medical history of asthma, POTS, and migraines, seen in this setting for recent syncopal episode. Okay, so that would be like your opening statement. They give some suggested or guiding questions in this one. In my opinion, I think it's a little bit off kilter. Like it doesn't really help you in the setting. The first piece is that it's an initial data gathering, that initial interview stuff. I'm with you, the symptom history, mechanism of action, that kind of thing. But the suggesting questions is asking you about how might your personal biases or some assumptions affect your interview? What is the value of the data that you gathered? What are some of the judgments you can draw from the data? In my opinion, this one, the suggesting questions kind of is a little off because this is like that opening statement. Keep it simple, keep it factual, give your information. Patient is a, blank-year-old gender with this past medical history, presents with these signs and symptoms, and is seeing you for this reason, period. There's also no reflection section on this first piece. So you don't have to go any further. You just have to give the facts. And in my opinion, that's a great way to open a case. So move on from it. Don't overcomplicate it. Section 2 is generation of the initial hypothesis or the PT diagnosis. So now this is asking you about body structure function, impairment, activity limitations, participation restrictions. So again, this section does not have a reflection. It does have some suggested questions. It states things like, can you construct the hypothesis based on the information you gathered? What is this based on? Your biases or experience? How did you arrive at this hypothesis? How can you explain your rationale? I kind of feel the same way about this section. Those questions are a little bit more leading, more reflective. There is no reflection section. So I really would give your PT diagnosis. Patient presents with impairment of gas exchange, impairment of ventilation, impairment of aerobic capacity in the setting of COPD, cystic fibrosis, heart failure, fill in the blank. Currently limited by impairment of strength, impairment of balance, resulting in multiple falls, like whatever that piece is, give that PT diagnosis statement. Patient, then give your little, your hypothesis to it. Patient shows good prognosis due to motivation, prior level of function, external factors including, right? So you're kind of using that ICF terminology to get your point across. There are some suggested questions at the end that I think help lead that, like how might the external factors affect your exam? How might internal factors affect your exam? I would say less affect your exam and more about that hypothesis. How is it going to affect the patient in the long run, right? So like, again, we've talked about this before. If patient comes in with some sort of limitation due to maybe a new surgical precaution, and that patient maybe is older. And so let's just give an example. Patient's an 88-year-old male, status post fall, resulting in a right hip fracture. Now status post, you can either say posterior total hip replacement, and then they have those precautions, or maybe this person now is status post IM nail and something else, resulting in non-weight bearing. 88-year-old male, non-weight bearing, is going to have a lot of limitations, right? Now, this is a very different hypothesis based on external factors. What does their home look like? What does their support system look like? What was their prior level of function? All of those things really play into your thought process on that overall picture. So I think pulling in the internal and external factors and prior level of function can really give a good initial hypothesis in that PT diagnosis piece. But again, there's no reflection. Keep it straightforward. Stick to the facts with that one. Section 3 is where the reflection piece starts to build. And again, you only need to complete 2 reflections. And I'm just going to double check myself. Yes, 2 focused reflections. So you could do more, but you're required to do 2. Just checking myself. Yep, 2. Okay, so section 3 is now entering the examination portion of the case. This is your section where you can just list out the tests and measures that you performed and the findings that you found. So the section itself is very straightforward. You list the tests and measures you performed and what they were. So blood pressure, heart rate, respiratory rate, whatever. And then because I typically do like pre, during, post, I would have that trend. Maybe you have MMT in here. Maybe you have a specific balance test. Maybe you did a specific special test for something orthopedic related. List it. What was your finding? Just facts, just like you're writing a note, right? Like this is just the black and white objective information. And then there is a reflection piece here. And so some guiding questions on that reflection is simply like, how and why did you select them? Why did you pick these specific tests for this specific patient? To me, that's a very straightforward question, very easy to kind of give your rationale here. You can then reflect on these tests and how may they support or negate your hypothesis. Does it help you? Did it help change your mind? Did it help kind of point you in the right direction? Do they have a minimum clinical important difference? So starting to pull some of that outcome measure information out of this piece. How did you organize the examination? Maybe the order of how you performed each test and measure was important or specific for whatever reason, and you could talk about that as well. And then how does your selection of tests and measures relate to the patient goals, right? So they can have a very nice overlay, and then you can have that discussion. In section 4, this is actually where you are going to upload your ICF chart. And then also there is a small section that you have to fill in on that piece. So you upload your ICF chart, and then you have to do a small interpretation of your clinical findings, diagnosis, and prognosis. So like there's like a small section that you can reflect on your ICF chart here. And then again, there's a reflection section. And this might be a good one to tackle because it kind of gives you room to talk about why you wrote the PT diagnosis that you did, why you have this initial hypothesis. What's another good suggested question in here? How might other factors such as bodily functions and environmental and societal factors affect the patient? So again, you're taking internal, external factors, that ICF terminology, and how it's going to impact that hypothesis. What's your rationale for the prognosis, right? There are times that we say like, prognosis is good because X, Y, and Z, or maybe patient's near baseline level and doesn't show good potential for progress. Why, right? Give some of that rationale. And then there's even a suggested question about behavior and motivation, readiness. We all know that that plays a huge role in recovery, right? What is your patient's buy-in at this point? And if you have a case where maybe the patient isn't bought in, but the family is the one who's kind of pushing this plan of care, you can discuss why maybe you have a poor prognosis, right? So you can throw that into the mix. So I think that section actually leads a really nice reflection point. Trying to see if there was something else on that section 4 piece that I was missing. Hold on, I'm going to let it load. So apologies for the delay. I've probably been logged out a whole bunch of times now. Yeah, this is the one. It gives you a section for entry. So like a typing section. And in that section, it wants you to talk about interpretation of your clinical findings. It wants you to talk about the diagnosis and prognosis. So its section is written as evaluation. So in my opinion, this would be a good place to basically write up your assessment, your synthesis, right? So kind of pulling in that thought process from your examination and such into leading into that prognosis piece. So again, there's a little bit of overlap on how they ask the questions, but in theory, that evaluation portion is really where you're synthesizing the information and giving your perspective. Section 5 is your plan of care. So you're going to list out short and long-term goals. I recommend that you write, how many days or weeks you're including in the short versus long-term goals. I want to remind you that typically when you're writing goals, it should be objective, measurable, and functional, and of course, timely, right? There should be a time component to it. So try to throw some function into it. What's the why? Also, make sure that you're including your patient's goals in that or writing them to reflect your patient's goals. In this same section, you're going to identify outcome measures potentially and PT prescription. So your frequency, intensity, how many days a week, how many times a day, for how many weeks, that statement. That's going to look very different between settings. So whatever it is that you are recommending for this person. In the world of outcome measures in this section, see, outcome measures kind of comes in quite a bit. This would be showing that change over time. So like what outcome measure is really going to be your tell that we've made some clinical improvement, has a good MCID. So just make sure that you're thinking about your outcome measures before you pull this information into the case. And there is going to be some duplication of information. This also has a reflection section. And in this section, it tells you, or some suggested guidance is, how have you incorporated the patient and family goals into the plan of care? How did the goals reflect your examination and evaluation? It wants you to use ICF framework. Why did you choose the PT prescription that you did? And then again, it pulls in personal environmental factors into that plan of care. I would also add discharge, right? Like what's the plan for discharge? So again, that's going to look very different from setting to setting. Like what is it going to determine? What's the plan for discharge? Are they discharging back to work, to school, to sport versus to home, to SNF, to acute rehab, right? Having part of that as your plan of care should also be included. And then why, right? So I think that could be another great reflection piece. Section 6 is called interventions. And so essentially you're going to list out the interventions that you plan to perform, have performed, however you want to write that. It also suggests that you write it as your approach to the interventions, prioritizing specific interventions, describe your plan of progression. How are you going to progress said intervention? And then any educational interventions. And so I think as PTs, we do a really great job with this. There is definitely going to be some education component in your session. This is where you would add it. This also comes with a reflection piece, and this one has quite a number of suggestions, including types of strategies like motor learning, principles behind your interventions, rationale for the choice of interventions, how it relates to the primary problem utilizing ICF, how might you modify your interventions for the patient and or caregiver, what's your criteria for modifying, do you have to coordinate anything, how do you ensure safety, communication between team members. So this one could take lots of different formats. Don't try to answer every question. Pick, the interventions that you're choosing. Why did you choose them? How are you going to progress them? How do you choose to progress them? What's your strategy behind your intervention choices? Do you have a specific strategy, style, what have you? Are your interventions evidence-based? Those things are things that you're starting to pull for later on, right? So if there's a specific intervention that you like to use, I think RMT is a really great example, right? There's lots of literature on benefit of RMT for a number of different reasons, right? So I could work that in if I utilized RMT with a specific patient. And then what was my why? Why did I choose it for this patient? What does the research support? So you could throw that reflection piece in there. I think you can spend some time on that one. Don't go crazy. Just stick to the facts, stick to what you did. Think about why you chose what you chose, and then, literally describe that process. Okay. Section 7 is considered re-examination. And basically it just says when and how often. So that could be as simple as every 30 days, right? So it doesn't really indicate that you need to now discuss what you did on re-examination. In the acute care setting, this might not ever happen. This may never come to fruition. So I think this is one of those things that you could kind of just keep it plain and simple. Like typically 30 days is a normal re-exam time. And so you would just write that. And for me, I typically write, because we're in the acute care setting, although it might not be an official re-examination, you might be adding examination tests and measures as the days go on, because the patient is more capable of now performing said activities. And therefore, although we technically only perform a re-examination at the 30-day mark if the person has a long length of stay, you are performing pieces of the examination daily based on the person's tolerance. And so I throw that in because I think that's an important piece, right? Like on eval, let's say I have a patient in the ICU who might still be vented or attached to CRRT. I might not be able to do a full test and measure list that I would normally perform, but as the person starts to progress, I may start adding in some of those exam techniques. So maybe I never see them at the 30-day mark, or they discharge before that time, but there were still some things that occurred to basically reassess, re-examine. So that's kind of where my reflection comes in on that, because that tends to be a commonality in my patient population. Again, this has a reflection piece. It has lots of guiding questions. Evaluate the effectiveness of your interventions. Did you need to modify anything? So this is a good time to say maybe that you are seeing this patient on an outpatient basis one time a week, and now you hit your 30-day mark. How are those interventions doing? Are they effective? Did you need to modify? Did you need to progress? Right? So there's a lot of ability to kind of reflect on this piece, even though the section, the mandatory section doesn't really necessitate a lot of information. It gives you the opportunity to say maybe that you overlooked or misinterpreted something, or over or undervalued a piece of your exam. Maybe how your therapeutic relationship has changed, the interaction between patient and caregiver, right? It depends on the scenario. So it gives a lot of room for your take on the situation. So, you can kind of run with that one, or you can keep it simple. Reexamination, when and how often? When? Every 30 days, continue throughout, right? Okay, section 8 is outcomes. So again, outcomes is back. This one has its own section. So describe outcomes that you used of physical therapy. And then this is where they want you to incorporate discharge plan, which includes follow-up appointments, equipment, schoolwork, community, or like reentry into sport, for instance. So this is kind of black and white. What outcomes are you utilizing to make certain decisions? What is the plan? And then it could say, like, what was the outcome of therapy, right? Like, what was the overall picture? Were they able to return to sport, return to work, in what time frame? So you can kind of work that either way. In their guiding reflection, it kind of gives that same nuance. So was PT effective? What outcome measures did you use to assess the outcome, right? So it throws in the outcome measures to determine if the outcome was met. Was minimum clinically important difference met? So that is a very, straightforward question. Were they able to return to work, sport, whatever they're doing? In what time frame? Was it the time frame that you expected? Did it meet your hypothesis, your prognosis, your plan of care? What might PT look like in their future? Do you have any follow-up plan for this person? Did you have to order any specific equipment? All of that. So you have a lot of room for reflection there. When they're talking about outcomes of physical therapy, they're talking about the end result. And within that end result, they want you to talk about the outcome measures that you utilize. So you can see there's some like semantics with words and things like that. The guiding questions, for the most part, are very helpful to kind of lead you in the right direction pretty much throughout the whole case. And then the last piece is an overall summary reflection. So basically, this kind of gives you, again, some room to talk about the whole experience. What was your impression from working with this patient? Did this patient change the way you do anything in the future? Was working with this patient, has it affected your clinical practice? How does this patient inspire you to advance your expertise or something? There's like, what's the impact of this specific case on you? And typically, and this is why I said what I said in the beginning, you want to pick one of those cases that really kind of moves you a little bit so that you have some, passion behind this write-up in some way, right? You have some feelings about it. You have some opinions this way or that way. It was really good or it was really negative. Sometimes those polarities can like give you some good reflection points. And then the last piece of this is references. So you need to list out your references for the case. The references should reflect your interventions, your outcome measures. I think those are usually the big areas that you can reflect back. Maybe there's a diagnosis, like a clinical practice guideline, like heart failure would be a really great example. I would include my clinical practice guideline for heart failure, and then hopefully my interventions and things that I was doing reflects the guidance presented there. Okay, we made it through that whole case. So hopefully going through ICF verbiage and patient-client management verbiage was helpful before going through the case. I think if you're trying to do both at the same time, it's just like too much information. So if you are going to sit down and do this MOSC, highly recommend that you listen to ICF and patient-client management model before you sit down and start writing up your case. And if you're going through the other piece, part 2, just play it while you're kind of going through it. Stop and play, let, guide through that, and you're going to be good to go. If you do this over time, or you're planning to do it over time for your future, listen to it now, kind of have an idea of the things you need to collect as you're going through your years, or maybe look for opportunities to step outside your comfort zone, right? Like maybe you have an opportunity to teach a class or guest lecture or run a lab or help in a community something or other. But it sort of makes you think about what kinds of things or what kind of goals you need to set for yourself in order to have some variety in your practice. So that will help you. And if you're kind of last minute, like I am truly, and you're, working through this, have a listen and work through it as you're going. So hopefully this was helpful. Let me know if you have any follow-up questions. If you need help on a one-on-one basis, I'll have my meeting link down below. If you enjoyed this or you know someone else sitting for the MOSC, please share it. And if you want, drop some stars, write a great review. It is greatly appreciated. Thank you so much for being here. Thank you for listening and being part of this. And I hope you have a wonderful day. And whatever you have to do, get after it.